Well, good evening. Welcome to the ANMS Virtual Symposium. My name is John Pandolfino. I'm the outgoing president of the ANMS. And before we get to introductions, I just want to make sure that everybody remembers that we're having our meeting, August 11th through 13th at the Fairmont Austin in Austin, Texas. This will also house our Young Investigator Forum from August 10th to 11th right before the conference. So certainly looking forward to seeing everybody in a new venue that we haven't used before. I also want to remind everyone of the ANMS Fellows Advancing Motility meeting. Application deadline is May 1st, 2023. And then, of course, we have a few other ANMS virtual symposia coming up. One on April 19th on visceral pain, what's the latest? And then we have on May 17th, cannabinoids and psychotropics. So without getting further delayed here, I want to introduce our virtual symposium this evening, Endoflip Uses and Limitations. Tonight, I feel like a proud father because I get to introduce our moderator, who's one of my former esophageal fellows, Dr. Anand Jain, who's now at Emory doing spectacular work. And he'll introduce one of my other former fellows, Dustin Carlson, who's now my partner, and also Adriana Lazarescu, who probably wrote one of the most important papers in my career, who showed me that perception of dysphagia was not due to just physiology and physiologic abnormalities. So without further ado, I will hand it over to Dr. Jain.
Thank you, John. It's an honor to have you all for the symposium. We're all very passionate about Endoflip. So, without further ado, it is my pleasure to introduce our first speaker, Dr. Dustin Carlson. Dr. Carlson is an assistant professor of medicine at Northwestern University's Feinberg School of Medicine. He's director of the Esophageal Center at Northwestern, and he's director of Northwestern Mott's Tonelli Esophageal Function Lab.
Thank you very much, Anand. Thanks very much, John. And really, thank you all for joining us tonight. Thanks to Lori and Stephanie as well. And I was just happy to be here. Everybody see my screen okay? Hear me okay? All right. All right, so I get the opportunity to talk about clinical uses and limitations of FLIP this evening, which is, of course, one of my favorite topics. All right, a couple of disclosures. All right, for those of you who are not familiar with the FLIP, we'll just do a brief introduction of the device itself. And so this is a device that's a bag housed on the end of a catheter. And within this bag, there are 16 channels of impedance that provide the technology of impedance planimetry, which allows measurement of 16 diameters along the length of this bag. And then while the bag is filled with conductive fluid in the esophagus, you actually can assess the esophageal response to distension. Now, of course, these 16 channels of diameter are paired with a pressure sensor in the bag as well to allow this assessment of the relationship between dimensions and pressure, or distensibility. Though more than just measuring distensibility in diameters, we're also able to assess this contractile response to distension. And so we can see here in this example of someone with normal peristalsis, the sustained distension associated with the FLIP study actually elicits this repetitive antegrade contraction, or RAC pattern, we believe represents repetitive secondary peristalsis. And thus, when this is performed at the time of a sedated endoscopy, it really provides a comprehensive assessment, a panometric assessment of esophageal function, where we can see opening and distensibility of the EGJ, we can see the distensibility of the esophageal body, and then also this contractile response to distension. And so, thinking about a few clinical uses of FLIP, I want to take it at least in a kind of in a step-by-step process, but I think certainly with this assessment of esophageal motility is one of the things that has provided a lot of interest and promise in recent years. And even within there, it's first, I think that one of the main examples or primary benefits is to use this as a complementary tool, particularly to clarify some of these inconclusive motility evaluations. I think there's also an emerging role for using this more for an index at the index endoscopy to really define an esophageal motility diagnosis during the index evaluation and really set the stage for future treatments or evaluation. There's also a significant role in evaluating treatment effects in achalasia. One thing I won't touch on today, just for the interest of time, is looking at tailoring fundoplication and anti-reflux surgery. I know some emerging use and interest there. And finally, there is a use for FLIP to assess EOE and stricture stenosis and severity. All right, getting right to it. I think one of the primary examples here for use of Endoflip is in this evaluation of these equivocal motility diagnosis. And even as recommended by the Chicago classification version 4, is when there's an inconclusive manometry and this EGJ outflow obstruction, or when there's elevated IRP, but peristalsis is present such that achalasia is not diagnosed, is a prime example where an abnormal FLIP or TBE is recommended to really help differentiate from a inconclusive manometric diagnosis of EGJ outflow obstruction or a conclusive diagnosis of EGJ outflow obstruction. And in the absence of really confirming the conclusivity of this disorder using a non-manometric test like FLIP, the Chicago Classification Working Group strongly recommended against pursuing definitive achalasia type therapy in patients based on that manometry alone. And this has been looked at in several studies, but one in particular that we recently reported looked at a sizable cohort of patients that had EGJ outflow obstruction defined by Chicago classification version 4 on manometry alone, and broke these patients down using Endoflip findings to look at based on normal EGJ outflow obstruction, inconclusive EGJ outflow obstruction, or those with conclusive EGJ outflow obstruction. And we also saw parallels with independent data using barium esophagram. We also could see that this actually had an impact on response to treatment. And of course, response to treatment needs to first be defined as to whether or not these patients are treated like achalasia, so with LAS targeted therapy, or if they're treated conservatively. And as we would expect, those who had conclusive EGJ outflow obstruction based on both manometry and FLIP had a relatively good response to achalasia type therapy, over 70% of them having a positive symptomatic response, whereas those treated conservatively really had uniformly had persistent severe symptoms at follow-up. Those, of course, who had normal EGJ outflow obstruction were rarely treated like achalasia, as they should have been. But those who were managed conservatively also had good symptomatic outcomes at the follow-up period. And unfortunately, there are inconclusive FLIP studies that in the setting of an inconclusive manometry had fairly mixed responses, recognizing some of the difficulty in this population, but also that need to use even additional testing sometimes when there are persisting inconclusive findings. But additionally, talk about FLIP at the time of an index endoscopy. And of course, when we're evaluating patients with dysphagia or even other esophageal symptomatic syndromes, upper endoscopy is often that first diagnostic test. It's often to be performed for many scenarios. And often it may find an objective diagnosis, in which case additional testing, manometry, FLIP, or other may not be needed, but yet a treatment can be directed based on that alone. But very frequently, probably more than half, if not more than 3/4 of the time, that endoscopy is normal or suggestive. And that's where FLIP panometry can actually help evaluate esophageal motility during that index endoscopy to really help direct whether or not additional testing, such as manometry, is needed, or if a completely different treatment pathway can be taken that may have actually not even need manometry to be performed. We proposed a classification scheme that was using FLIP panometry findings and really assessed EGJ opening based on a probability of EGJ obstruction. That's when EGJ opening is normal. There's a low probability of EGJ obstruction. High probability of EGJ obstruction is when there's reduced EGJ opening with a low EGJ distensibility index and a low EGJ diameter, but also combining this a contractile response. So a high probability of normal peristalsis when there's a normal rack pattern, or a low probability of normal peristalsis when there is signs of impairment or even absent triggering of the contractile response. And together, these patterns can be combined to define esophageal motility during endoscopy. And when we looked at this FLIP classification compared against high-resolution manometry in the Chicago classification, we found that normal FLIP panometry pattern was actually associated with 95% of manometry findings that are either normal or ineffective esophageal motility, which in my mind is essentially normal. So finding here where the probability for having a major actionable motility disorder is going to be very, very low. Kind of on the other end of that spectrum, was a finding with a very abnormal flip, the achalasia pattern flip, where there's reduced EGJ opening and also an abnormal contractile response. And when this was found, over 90% again with conclusive disorders of EGJ outflow obstruction on manometry or TBE in the setting of EGJ outflow obstruction. But so here, there's often that kind of question comes up if these are scenarios where manometry could potentially be deferred. And I think that we've reached that point now where we definitely could consider deferring HRM and treating motility disorders alone if there's a low probability of a clinically relevant actionable HRM diagnosis. In the setting of a normal flip, I think we've reached that finding based on a normal endoscopy and a normal flip. In the setting where there's an obstruction with weak contractile response, obviously here, there are a few patients here that don't have an achalasia syndrome, but if paired with a very supportive endoscopy finding, good clinical history, maybe a good barium esophagram, I think a clinical diagnosis often can be very reliably achieved based on that workup to that point, and manometry may not add much beyond what's already obtained. However, that flip at the index endoscopy also can help support pursuing additional findings to help characterize spasm, or certainly if there is an inconclusive or borderline findings, again is where manometry or barium esophagram can be pursued, and flip helps support the pursuit of those additional studies. All right, but moving on, another clinical use for flip is obviously evaluating treatment effects in achalasia. I'm borrowing some data from my surgical partners. You can see that the distensibility of the EGJ can actually be tracked over the course of a laparoscopic Heller myotomy. And similar findings seeing that increase in EGJ distensibility over the course of a palm. So this can help guide myotomy and potentially help avoid that incomplete myotomy. And there's even been suspected there may be a sweet spot where obstruction can be relieved, but maybe reflux would have a lower probability of occurring. I'm not quite sure that upper end of the sweet spot is as easy to obtain, but at least with avoiding incomplete myotomy. You know, most surgeons that I talk to nowadays find using flip to be an essential part of their achalasia therapies with either palm or Heller myotomy. And further, our surgeons actually looked at a series of their palm experience at a time when they had flip available and other times when they did not. So it wasn't like there was patient selection driving whether or not flip was used, more based on a randomness of availability, so to speak. But they found that they actually had better palm outcomes looking at follow-up and symptomatic Eckert's score when flip was available compared to when palm was performed without flip. And furthermore, using flip to help tailor the completeness of myotomy, they even found that in almost 2/3 of the cases, that when they used flip, they actually were performing additional myotomy, so helping them tailor the myotomy and avoid an incomplete myotomy during the procedure. There's also a role for flip here when people are returning after achalasia therapy to see the adequacy of myotomy, but also to look for other levels of obstruction that may be causing symptoms at that point. And a variety of studies have looked at this and have demonstrated that reduced EGJDI is associated with a poor treatment response when seen at follow-up after an achalasia therapy. And for the most part, the EGJDI has carried stronger associations with outcome than manometric LAS pressure. And here's one such study, actually, in which Dr. Jain was the lead author, looking at flip and EGJDI and seeing significant differentiation between patients that had retention on esophagram and those who didn't. Whereas when looking at the manometric parameters of either IRP or basal EGJ pressure, there's really substantial overlap in the degree of retention seen on the barium esophagram. All right, also there's, I think, a role for flip and EOE, certainly to identify when stenosis is occurring, but also to help gauge the extent and severity of the narrowing in EOE. Here's an example here where a 16-centimeter flip is positioned in the distal esophagus, but then also pulled back to a point where we can actually see the rest of the esophagus and can really appreciate that there's a narrow caliber esophagus here that involves from the EGJ nearly the entirety of the esophagus with a little bit of sparing proximal. Now, of course, this can help phenotype this patient as a narrow caliber esophagus and also help direct basically the size of dilation, not to mention the need for it here. But an example here, seeing the sensibility plateau in the proximal esophagus of about 12 millimeters. After a 13.5 millimeter dilation, a nice mucosal break representing the response to the dilation at that area. And this has been shown to have clinical relevance, of course, with association with food impaction, need for dilation. And I think there's going to be more to come with FLIP here as far as clinically phenotyping these patients, as well as a role to help monitor disease progression and maybe even response to therapy in EOE. Now, of course, the topic I was given, so not just to describe clinical uses, and frankly, I can go on for another hour or two about clinical uses and benefits and mounting data to support those. But of course, we have to look at limitations as well. And so a few that came to mind that I at least wanted to touch on briefly. I think one of the limitations here is just that we're still in some ways seeking ways to have a more generalized and consistent application and use. And a few things that this relates to, I think, is one with the study protocol. There's also this concept of a dry catheter artifact that I think is gaining some recognition, and is something that needs to be taken into account when interpreting FLIP manometry studies. And then another issue that I see still kind of prevailing is some of these isolated application of metrics. Often this is just using the EGJDI in isolation and not really using some of those other factors that FLIP also provides, like EGJ diameter or pressure, which are also important arbiters that can drive the DI one way or another. Other limitations here, certainly there's still the lack of commercially available analysis software. And so even though we've made a software available that can be downloaded free and used for research purposes, there isn't something that's yet available commercially. Another issue that we see, and I often get a lot of questions about this, is that FLIP is similar to, but it's not the same as manometry. I throw this in here, not really thinking that it's truly a limitation, but more that it can cause some question. I think that this is recognition of this response to distension versus response to swallows, and I'll come to this more in a minute. And of course, similar to manometry, both FLIP and manometry can have inconclusive and equivocal findings. I think that is just another one of those scenarios where complementary use of multiple tests will remain needed for a lot of the patients that we see in this space. So just kind of going through those in a little more detail. I think one is the recognition of this kind of lack of a standardized protocol. We've had a variety of studies and have described an approach to assess EGJ opening, contractile response, and part of that does involve a standardized protocol using stepwise distension, typically with a 16 centimeter FLIP balloon using 50, 60, and 70 ml fill volumes, and then to really have a volume directed analysis to look at this contractile response across this entirety of this study portion, to focus on the EGJDI at the 60 ml fill volume, and to use the maximum EGJ diameter achieved at either the 60 or 70 ml fill volume. So as I am seeing more and more people using FLIP and even starting to send us studies for interpretation, one thing in particular that I see uses the omission of using this the 70 ml fill volume with the FLIP study. However, that is an important component of the study, and often in omitting that, the EGJ is not really interrogated as potentially thoroughly as it might need to be, particularly in patients with suspected achalasia or relevant EGJ outflow obstruction. Also, as I mentioned, there is a commercially available software that our chief engineer, Dr. Walter Koo, has posted on his website. That is something that's available for use. It does require the archiving of the FLIP data file, so something to consider as FLIP studies are being performed. And this can help visualize some of the FLIP data for use even after the endoscopic encounter. I also want to point out this idea of this dry catheter artifact. This is an artifact that occurs when actually occlusion of the FLIP catheter, typically with an occluding contraction, actually disrupts the electrical current that is needed for the impedance manometry technology. And when this does occur, it can create a bit of a falsely elevated diameter. And you can see this example here where this occluding contraction occurs, secondary peristaltic wave, and can make this EGJ here appear like it's opening to 24 millimeters. However, this is a patient with EOE that had a reliably identified stricture. And later on in the study, when those occluding contractions are no longer occurring, the stricture can be readily visualized on the FLIP catheter here. So it is one of those things that needs to be recognized. And once it's can be recognized, it's usually pretty easy to account for and just finding areas in which that dry catheter artifact is not occurring And when that's the case, reliable diameters can be measured along the length of the esophageal body and EGJ. All right. Also on top of here, this I toss in here, not really because it's so much of a limitation, but I think often as an opportunity, and just that flip is not manometry, and manometry is not flip. And even though these two devices test very similar function, and obviously are testing the same organ, they are testing different things. And with flip, this is looking at the esophageal response to distension. So secondary peristalsis, EGJ distensibility, EGJ opening, really some of the mechanics of the esophagus. With manometry, we're primarily focusing on primary peristalsis and deglutative LES relaxation pressures or EG outflow pressures related to contact on the manometry catheter. And so certainly there's parallel findings, and we see this time and time again in a variety of studies, but these different responses can yield different outcomes. And I see at times other physicians calling us saying they had a patient with normal motility on manometry, but then abnormal flip manometry finding. Like, what does that mean? How do we interpret that? I think there can be times when primary peristalsis can be intact, but secondary peristalsis may be deficient, and that could be signing a progression of dysfunction. But I think one unique scenario that is of interest is when these flip findings are abnormal in patients with normal manometry. And even when we looked at this, and in a large cohort of patients that all had a normal manometry, they had normal motility per the Chicago classification, we see that the vast majority of these patients had normal EGJ opening, but there is a small number here. And this was only 3% that actually had reduced EGJ opening, but almost a quarter of these patients had some borderline EGJ opening findings. I think this is just a testament that there are other factors other than just impaired LES relaxation that can be causes of reduced EGJ distensibility. And what this is, I think at times can be fairly reliable. The subtle stricture, wall fibrosis in certain scenarios. But I think there are other unique physiologies that need further investigation here to help us understand what this mechanism is for this reduced EGJ opening when endoscopy and even manometry are otherwise fairly normal. That said, this does seem to mean something. And even when we looked at this patient group in more detail, we could see here that at least on esophagram, those who had abnormal EGJ distensibility often did have abnormal esophagams. They had retention. And so there is something to this. There's some clinical relevance here. Obviously it's not uniformly abnormal, but there's other processes here at play. And so I think one of these other factors now that just needs added investigation is to help us parse out some of these other added mechanisms of this very unique response that we're eliciting on flip in that regard to sustained esophageal distension. That'll, in mind, I just think about where we stand with flip and comparing it with even the high resolution manometry and the Chicago classification. Certainly, the Chicago classification, we recently had introduced version 4 after over a decade of use with group input from international experts and a large working group. But still with ongoing refinement needed, even after all this wealth of experience and use. Certainly we're a little bit earlier in there with flip panometry and have defined some findings and are moving along making classifications. But ongoing refinement, ongoing improvement is to be expected as this continues to evolve and develop. And so with that, I'll conclude. And certainly, hopefully, I've covered that there are some vast and promising as well as evolving uses for flip clinically. Certainly help clarify inclusive manometries, also maybe even identify versus ruling out achalasia during an endoscopy. Certainly following treatment in achalasia as well as an EOE are two other very promising uses. And overall, when we look at this compared with other tests, really being completed during sedated endoscopy helps us enhance that endoscopic encounter and really can help direct even endoscopic therapies or allowing us to set patients off down a treatment pathway immediately after an endoscopic encounter. And so with that, I'll conclude. I thank you all for your attention and I look forward to questions when we reach that session.
Wonderful. Thank you, Dr. Carlson. That was a great talk. I forgot to mention before I introduced Dustin that as you all are posting some wonderful questions, continue to post them in the Q&A box. and we'll get to them after both talks. And whichever questions we cannot address due to time constraints will be answered on, you'll have an opportunity to post them on Doc Matter, and those can be answered. So let us move on to our second presenter. So it's my pleasure to introduce Dr. Adriana Lazarescu. She is Professor of Medicine at the University of Alberta in Edmonton, Alberta, Canada. She's currently the Director of the GI Motility Lab at the University of Alberta Hospital and the Director of the Neurogastroenterology and Motility Fellowship there. She is also co-founder and current president of the Canadian Neurogastroenterology and Motility Network, and her main clinical and research interests are in GI motility and medical education.
Thank you for the kind invitation to be part of this session and for the introduction. I'm going to share my screen. So following up on Dusty's excellent introduction to the uses of Endoflip, I'm going to go through several clinical cases, and they are mainly answering questions that perhaps other investigations did not make clear, or where there is discrepancy between investigations and symptoms. So we're going to go along and see how Endoflip can help in this situation. These are my disclosures. They're not relevant to this talk. And as far as objectives, I hope that you will determine when to use Endoflip for both assessment of esophageal function as well as determining management for your patients. So let's start off with the first case. This is a 34-year-old woman who has fairly typical heartburn, long-standing. The symptoms are most present during the daytime. She sometimes will regurgitate acid into the mouth, particularly when she bends over after a meal. She has some dietary triggers, including spices and fatty meals, but does not have any dysphagia, odynophagia, weight loss. Her BMI is 30. She's otherwise healthy, no medications aside from the PPI, which we'll talk about in a second, no allergies, no alcohol, smoking, etc. She was scoped, and the report notes no visible esophagitis. The G junction was described as patulous, and there was a small hiatus hernia. She has been on pantoprazole daily dose, and that works about 75% of the time. It was increased to BID, and it worked the whole time. However, as happens with many patients, she often forgets to take her medication, and then her symptoms come right back. So she was asking, is there anything else that I can do so that I don't take medications for the rest of my life? And the option of anti-reflux surgery came up. So as part of the workup for that, she underwent a 24-hour pH impedance study off PPI in order to confirm the diagnosis of GERD. And based on the Lyon consensus, you can see that her acid exposure time is 8% total, which is diagnostic of GERD. She has an increased total number of reflux episodes at 96 in the 24 hours of the study. And not only that, but her heartburn is associated with acid reflux, so positive symptom index and SAP. So it's a pretty robust diagnosis of GERD, and she responds well to the PPI. But then we come to high resolution impedance manometry. Her lower esophageal sphincter resting pressure was normal at 25, but the IRP, the measure of LES relaxation during a swallow, was elevated at 22, both in the supine position as well as in the upright position. The DCI was normal and all swallows were peristaltic, and the distal latency was also normal at 5.2 seconds. On impedance, there was no bolus retention noted, and there was no elevated intrabolus pressure either. She had a couple of provocative maneuvers, the rapid drink challenge and the multiple rapid swallows, and the IRP remained elevated, though there was no pressurization noted. The final report came back as possible EGJO, EG junctional flow obstruction, so inconclusive, partly because, as you know, from the new Chicago 4.0 diagnostic criteria for EGJO, which has been tightened from Chicago 3.0, you need several factors in order to confirm it. So you need obstructive symptoms, you need an elevated IRP, both in two positions, so supine and upright, and you need some another supportive test, such as an esophagram or endoflip. So when the patient first heard about the manometry report, she was worried. She said, well, hang on, if the esophagus is blocked at the bottom, can I still have anti-reflux surgery? Would that not just compound the problems and cause more symptoms? So this is where the endoflip was done, and this is a similar manometry as Dusty showed you. And essentially, this is completely normal. The distensibility index at the EG junction is normal, and I'll give you numbers on the next slide. The diameter is also normal, and you're seeing beautiful racks, so a good contractile response. This is a normal endoflip. So as I said, the EGJ-DI is 6.5, which is towards the upper limit of normal, often seen in GERD. The diameter is normal, racks present. So here's a patient who has normal endoflip manometry, has no obstructive symptoms, has no evidence of bolus retention. Essentially, this finding, so again, EGJO is a finding on manometry, not a disease or condition on its own. EGJO in this patient is likely an artifact. It could be related to the hiatus hernia, but essentially should not be an obstacle to considering anti-reflux surgery. So I think this case illustrates the fact that, again, manometric findings are not the law, they're not definitive. I often like to say that as much as we get annoyed sometimes by our pathology colleagues when their results say clinical pathologic correlation required, I actually think that our manometry report should say clinical manometric correlation required, because you have to put the findings of the manometry in the setting of the patient. So this is our first case. Let's look at a second case. And I have to say that Dusty and I did not actually prepare together, but he kind of scooped me on this one. So this is a similar case to one that he presented, but I would like to add a few points. So this one involves a patient with eosinophilic esophagitis, a 25-year-old man with dysphagia with solids for many years. It happens on a daily basis. His impactions are up to 5 minutes, and he has adapted. He is a slow eater, drinks lots of fluids with his meals. The formal diagnosis of eosinophilic esophagitis was made about a year ago, and he had typical endoscopic features and typical biopsies, typical symptoms. He has a history of atopy with asthma, so the whole thing fits. He was treated with topical budesonide, 1 milligram POBID for 6 months, and he reported still having dysphagia. So he was scoped again, and the EREF score had improved. So the endoscopic appearance was better, though certainly not fully resolved. And he had repeat 3-level esophageal biopsies, which were normal. So there were no eosinophils, there was no other abnormality. Essentially, his eosinophilic esophagitis is now in histologic remission. On endoscopy, there was no obvious focal stricture or diffuse narrowing. And this is where I'd like to maybe take a slight detour and talk about our visual assessment of the esophageal lumen. When I work with GI fellows, I always tell them that being inside a pipe, unless there is a very focal point of narrowing that brings you down, it's quite common to miss strictures, particularly if they're smooth and longer, and particularly if they're not at the GE junction. We are not as good as we think we are at assessing narrowing of the esophageal lumen. And as you all know, depending on insufflation, whether you're on your way back or on your way in, we've all seen rings that seem to almost disappear right in front of our eyes. And here's a study that actually showed that how terrible we are at assessing a narrowing of the esophageal lumen. particularly in patients with eosinophilic esophagitis. It was found that sensitivity for narrowing below 20 millimeters, which is the normal esophageal lumen, is 14%, and specificity was 79.2%. If you're looking for a narrowing below 15 millimeters, sensitivity was a little higher, but still really abysmal. And to prove that really, just because you don't see it, it's not there, they found that in patients with histologic remission of the eosinophilia, yet persistent dysphagia, if you just did an esophageal dilation, 86% of them actually felt better afterwards. And this is despite the fact that you couldn't really see a narrowing. So let me give you an example for this particular patient. And I don't have the actual picture of the endoflip, but you saw one with the distensibility plateau that Dusty showed. So if you use the catheter to interrogate the G junction, the maximum diameter is 18 millimeters, so that's normal. And the distensibility index is 4.2, so this is normal. And there were actually racks, and I didn't put that down. However, if you move the catheter further up into the mid-esophagus, there is a persistently narrowed diameter of 14 millimeters. So telling you that there is a stricture. Furthermore, if you dilate in a targeted fashion with a CRA balloon in this area, you do get a superficial mucosal tear, which is typical for eosinophilic esophagitis and typical for a true dilation. So if the lumen had not really been narrowed, you would not get that tear. So I think that this type of targeted dilation is very helpful. I know when I trained, we did savory bougie dilations. And then we would find these mucosal tears in places, again, that we had no idea had been a stricture, but the patient had been symptomatic, so that's why we did them. I do like the more targeted approach. That way you actually find out where the narrowing is and about how narrow it is in order to choose the right size of balloon to use. All right, so the third and last case that I will discuss is a case where the diagnosis of achalasia needs to be clarified. So we have a patient who's 44 years old, female, with progressive dysphagia, predominantly with solids, but also sometimes with liquids. And this has been going on for 2 years. She sometimes regurgitates what she describes as gobs of phlegm, but she does not regurgitate food. And a lot of this regurgitation is in bed at night, so she wakes up with it in her mouth in the morning. She does not describe any chest pain or reflux symptoms. She has no weight loss. She has no other diseases, diagnosis, and no medications. So she is scoped, and the esophageal lumen is described as normal, not dilated. There's retained frothy saliva, but no food. And the endoscopist notes the EGJO opens well, does not feel tight, unlikely to be achalasia. So this is where, again, I'd like to maybe take a bit of an editorial break and talk about the fact that a scope is a very artificial situation. When you come in with a scope, which is relatively large compared to some of the foods that we eat in particular, the fact that we insufflate, we may put water or air, we suction, all of that is various different stimuli for the esophagus. And that could stimulate relaxation of the lower esophageal sphincter, but that may not reflect good, consistent relaxation of the LES with swallows. So just the fact that you see the LES open during endoscopy does not rule out achalasia. And the fact that it doesn't necessarily feel tight or pop does not rule out achalasia. So I think that's a very important point. I have certainly seen diagnosis of achalasia be delayed because the patient was scoped. And again, the conclusion was, well, the EGJ opens well, it's not tight, it can't be achalasia. So it's something that I want to caution you about. The patient underwent high resolution impedance manometry and had a normal lower esophageal sphincter resting pressure, 32 millimeters of mercury. However, the IRP was normal. So according to manometry, the LES relaxed during swallows. There was no measurable DCI or distant latency because there was no peristalsis. half of all swallows would elicit panesophageal pressurization, while the other half was non-conducted. There was bolus retention noted on impedance, and the interpretation was, it kind of looks like type 2 achalasia, but the IRP is low. So this is where I take a moment and remind you about the Chicago 4.0 diagnostic criteria for achalasia. So you start off with the abnormal medium IRP, and from there you look for absent peristalsis, and all swallows either failed or premature, and then the three subtypes. So the abnormal median IRP is integral to the diagnosis of achalasia. However, studies have shown that there is a subset of achalasia patients that has a normal IRP, but in real life and in other supportive tests, impaired LES relaxation. So such provocative tests include a barium esophagram, Endoflip, and also the rapid drink challenge. So on rapid drink challenge, you're looking for, again, a persistently elevated IRP, but also pressurization in the esophagus. So this particular patient underwent an Endoflip, and there are no racks. There's really no contractile response in the esophageal body. The distensibility index is quite low, and the diameter is quite low as well. So this is all very much in keeping with a diagnosis of achalasia, despite what the manometry showed. So it's very important to note that we don't look just at the diameter and the distensibility index at the GE junction. We also want to see the contractile response, because compared to EGJO flow obstruction, where you would have a good contractile response in the esophageal body, for achalasia, you would not. So again, this fits with a diagnosis of achalasia. And for this particular patient, I am now comfortable that they truly have achalasia, and we can proceed with discussing management options. So in conclusion, I have discussed 3 cases to show the role of Endoflip, both as a diagnostic tool as well as one that can guide management. Dusty talked about using the Endoflip at the index endoscopy. I've given you some examples where this can be at a follow-up endoscopy for confirming or confirming certain diagnoses or ruling out certain motility disorders. So you can see that there is a variety of roles for this technology. All right, so that's the end of my talk. And I'm just going to stop sharing, and I'm going to give it back to Anand.
Okay, wonderful. Thank you, Adriana, and thank you, Dusty, for those wonderful talks. So now we will answer some of the questions. Thank you all for posting in the Q&A box. We have some great questions. And I think to start with, there were a couple of questions about using Endoflip in EOE, actually. So the first question, can you use Endoflip outside of a research setting in EOE? And if so, when do you all utilize it in your practice?
Adriana, do you want to start with that one?
Sure thing. So I definitely use it, but I don't use it routinely, because I think it depends on what your question is. So if you have a patient with EOE, you put them on medical treatment, you put them on elimination diet, whatever it is, and then you confirm histologic remission, and they're also in clinical remission, so their symptoms are fine. I don't know that doing an Endoflip would add much to that. I mean, obviously research has shown that the diameter can improve, the distensibility can improve as the fibrosis in the wall also improves with treatment, but it wouldn't change what I do. Whereas the case that I described, this is somebody who, from the allergic inflammation component, they're fine. That part is all good, but they still have dysphagia, and you want to know where they're obstructing, essentially. Is it at the G junction? Is it higher up? And if you can't see an obvious stricture or ring, I think it's very helpful. But yeah, I basically use it in a targeted fashion to answer a specific question.
Okay, great.
Yeah, and I feel like, yeah, I'm still also kind of figuring out like kind of what that rule should be for myself in using Flip and EOE. I think to the first part of the question is, I think it's definitely there and ready for clinical use and does not need to be part of a research protocol. I completely agree with Adriana in that, yeah, the people who are coming back who appear to be treated but yet are still having ongoing symptoms. I mean, right there, it's a no-brainer that I'm using Flip in that EOE patient every single time. And yeah, and sometimes it's either picking up subtle stricture and really helping direct dilation. Other times it's doing the opposite. And obviously you're giving us that added reassurance that there isn't, kind of unappreciated, stenotic changes that are driving symptoms. And then, yeah, we shift focus more to being the some of those perceptive factors. Though I will say that lately I'm finding myself using Flip more and more kind of in my routine evaluation of many EOE patients. And even just that, I feel like it often does really kind of help kind of set the stage for the severity of the illness. People who I am going to be, following closer, people who I'm going to be a little more aggressive on treatment. Do I need to get the EO counts down to less than 15, less than 6, or can I sit there because they're doing fine and haven't remodeled with EO counts in 20 even on, maintenance, topical steroid, things like that. And I think it is kind of helping me figure out how to monitor people. Hard, fast rules, every single patient, not quite there yet. But yeah, I think the story is still kind of being written for Flip and EOE, but certainly useful and in a lot of scenarios already.
Okay, great. Yeah, those are great answers. A follow-up to that is the technique. So is your technique for using EOE the same? Is it any different? Could you all speak to that?
Dusty, why don't you go first for this one?
Sure. Yeah. So one thing, when I mentioned about, kind of showed that slide on the protocol, that really is our motility protocol with that positioning across the EGJ and uniformly going up to that 70 ml fill volume. In EOE, I'm always starting with that same protocol, but really here kind of based on that initial endoscopic assessment, if there is stricture, if there's kind of some concern for high grade rings, narrow caliber, I'm watching the pressure a little more closely and I may not uniformly go all the way up to the max fill volume. But really once the pressure is getting up to being consistently around 50s, 60s, I don't need to really add more fluid to the Flip at that point. And so yeah, we would cease the filling and kind of have our measurements made at that point. I am pretty routinely both assessing distal and proximal esophagus though. So after I've completed that proximal or that distal esophageal exam, I then will lower the amount of fluid in the bag, usually not to empty, but sometimes somewhere in the 30 to 40 ml fill range, kind of depending on the degree of narrowing. And then pretty slowly and carefully withdraw the Flip into the esophageal body, kind of right up to the point where we're just starting to see the narrowing at the upper esophageal sphincter, and then I advance it in just a little bit beyond there. And at that point, when the Flip is completely encased within the esophagus, I'm even more carefully watching the pressure. You don't kind of have that outlet in the stomach like you do with the distal positioning. And so there, yeah, similarly do a stepwise filling protocol and come up until that pressure is somewhere in the 50s or low 60s and call it a day.
I
Okay,
do the
great.
exact same thing. So.
Yeah, absolutely. And I do as well. So that's great. Okay. So there were a couple of questions about sort of other indications other than evaluation of traditional esophageal dysmotility. So the two questions were, is there any role for Endoflip in post-fundoplication dysphagia? And then also there was a question about evaluating the pylorus with Endoflip. Is there any normative data for that? Is that something that has any value?
So I use it in post-fundoplication dysphagia a lot, and I find it helpful because, again, I think that our endoscopic assessment of the G junction is not that great. So remember, your scope is 9.9 millimeters in diameter. So really, the G junction would have to be very tight, for you to really feel it. So I find it's really nicely objective. And oftentimes, I don't know about you, but our surgeons are like, no, it's not too tight. I know for sure it's not too tight. but I can actually show them. I can show them this is the diameter, this is what it is. And it helps if you are going to go dilate, you can recheck to see what your new diameter is. So I don't do much on the pylorus, so I maybe will give that to Dustin.
So,
No?
yeah, I should have gotten first there. I didn't realize you did. Yeah, no, I frankly have never done a pyloric flip. So yeah, I don't know what my esophageal flip number is at this point, 1,000 plus. But yeah, I've never done one of the pylorus. I mean, I do know there is normative data that's out there. Yeah, nice study from Dr. Camilleri within the last couple of years that did on a lot of patients. And so there is some normative data. Yeah, I think that's, you know, at least people in the gastroparesis space are liking it as at least another way to help, you know, hopefully find a phenotype of gastroparesis that may be more amenable to, you know, pyloric targeted therapies. But yeah, but I don't use it, and so I don't feel like I could speak to it all that eloquently. Yeah, but also, yeah, compared to, but post-fundoplication dysphagia, yes, I also like using Endoflip there, and yeah, for those same reasons. I think one thing when I'm doing it there, you know, the normative values and kind of what really is kind of relevantly lowered, I think is a slightly different window, and even just kind of based on some, you know, the intraoperative flip studies, you know, those post the kind of final measurements are, you know, kind of low, almost like achalasia level DIs, and yet, you know, these patients do okay for a time. So I'm always kind of keeping that in mind a little bit when using it. But I think at least at the extremes, it is really, really helpful just to show, you know, significant narrowing, or, you know, the converse when it's, you know, very wide open to kind of help, you know, cue in on areas of pathology that can be targeted for treatment. And again, I think that population in general is just such a, you know, difficult and complex one that more data is often just helpful to really try to figure out how we're, you know, best treating them and monitoring over time.
Okay, great. Thank you for those answers. So that's a good segue into one of the other questions, which was actually, when do you use it after myotomy? And if there's a particular technique you would recommend, is it a continuous sort of inflation was the question, or do you still do the stepwise distensions for after myotomy?
Yeah, I suspect that if it's continuous, they're probably suspecting like during myotomy.
Yeah, they want it to be. They want it to be.
Yeah, so surgical use. Yeah, so maybe disclaimer: I don't perform POEM, I don't perform Heller myotomy personally, but I would recommend that. Yeah, really to try to make, you know, mirror that protocol. That, you know, the active distension is a component of the measures, and I think it does help keep it consistent. You know, over time, lower esophageal sphincter tone is probably gonna, you know, kind of reach a point of exhaustion, and so can maybe alter the measures a little bit. So I do think that, yeah, kind of repeating the same steps, repeating the same protocol is better to use kind of with repeat measurements during myotomy, as opposed to, yeah, just leaving it in place. And I know even there can be some concern with actually the cautery causing some injury to the bag or disrupting the sensors a little bit.
Right. Okay, great. And then do you have a goal DI that you recommend for your surgeons to target after myotomy?
Yeah, I think our surgeons have kind of set that to them for themselves. And for the most part, I know they like to at least get a DI up above 3, or they want to see at least doubling from the baseline if they're not quite at 3. But 3 is the number they typically are shooting for. I know even in some of their earlier work, they were showing that, you know, that potential sweet spot was kind of in the 4 to 8 range, and, you know, I think a lot of those things.
One thing I would say is we all know that post-op there is a period of adaptation. I actually restage all of my achalasia patients 6 months post-treatment, whether it's POEM, Heller, whatever, including an endoflip, because as Dusty mentioned, I mean, intra-op, there are going to be changes for sure, but as to where it settles longer term, I want to give it a few months to see. And that's also a nice baseline to have, you know, if they get into trouble later on.
Okay, yeah, that's great. That's a great protocol. That's our protocol here as well. Okay, and then there's a question about, this is an interesting one, about normative data in the proximal esophagus. do either of you have experience with these proximal esophageal flips? Do you see contractions there? To my knowledge, there's no normative data that's published, but I'll let you all answer the question.
Yeah, in our normative series, we did actually include a small subset that we had done that proximal assessment. We didn't actually, I think, include the motility data there, but you actually do. You see the rack pattern in the majority of them. One thing that actually was kind of one of these, learn from your mistakes type of thing. But when we did those studies, we had the flip actually kind of cradled right in the upper esophageal sphincter. And I know we said that the distensibility plateau, we were really more focused on the body, and we were uniformly seeing that it was well above 18, but we actually were seeing that it was more like 24, 26 millimeters. And looking back, it was that the positioning across the UES was completely, basically artifactually elevating our data, and we were getting a lot of that dry catheter artifact. Yeah, when looking back there, I mean, that proximal DP distensibility plateau, that is, it still is the same as distal and should be more than 18 millimeters. But yeah, it was kind of one of those learn from a mistake type of scenarios.
Yeah, no, that's a great answer. And then Adriana, how about the significance of peristaltic fatigue as the flip study goes on? If you have a patient who starts off with racks and it fatigues later, do you attach any significance to that or not necessarily?
No, not really. I mean, if they have normal racks for a few of the volumes, we often see them actually fade a little bit later on. So I don't consider that to be a significant problem or an indication of an abnormality in the esophagus.
Okay. Yeah, I agree. Dr. Carlson, you agree too with that?
Yeah, totally. It's what one of the things that John and I joke about, and John likes to call the paradigm of flip. And that, yeah, with increasing volume, it can look like the flip is weakening, like the contractile response is weakening, but it really is actually a more powerful contraction. It's just that the diameter changes are less because the bag is more full and even overinflated when you're getting up to that 70 ml fill. But yeah, but looking at like the work or power of the esophagus, it actually is squeezing even stronger at that point.
But in a sense, it's almost like the balloon is splinting it open, right? It's not the luminal diameter is not actually closing down quite as much.
Oh, exactly. Yeah, that's where the diameter change is smaller, so that's where it looks kind of lesser on the output. But yeah, it's still not really weaker. Just has that appearance.
Right. Okay, great. And so just a couple more, and then I think the rest, we can have the be posted on Documenter. But maybe two more questions. One question was a practical question about implementing Endoflip in your clinical practice. Who sets up the Endoflip, and how much time does it take, etc.? Do you all have any guidance for the audience?
So I assume that Dusty has this crazy research protocol. Maybe not. For me, it adds about 5 minutes to my scope. Believe it or not, the biggest delay is actually when the balloon has to deflate. It's just so slow. I mean, I talk about that being, the watching paint dry component of the day, because it's just, you're sitting there as it's slowly deflating. Otherwise, basically, my nurse has the actual piece of paper where we take all the measurements, and I insert the catheter. I hold it and I push the buttons to fill the balloon and stop and so on, and I just call out numbers to them, and basically that's what I do. Dusty?
Yeah, we don't have a crazy research protocol. We do have really good motility techs that we do offer to some of our partners to help them do Endoflip, and they have some familiarity with it and can help set it up and even help with the protocol and things. I moved to mostly I do it myself, and I set it up and place it and push the buttons, and yeah, it is very easy to learn to run the setup and purging protocol. And yeah, and even the setup, there's an initial purge calibration cycle that takes about 2.5 minutes. But usually you're doing that as the patient's coming in or being sedated. And yeah, in the actual study itself, yeah, maybe adds 5 minutes, 8 minutes if you wait for it to completely empty before moving it. But I agree with Adriana. That emptying time is the worst. And just because all the fun and excitement when you're filming is so cool. What are we gonna see? How useful is this? And then with emptying, it's it's kind of a big letdown, both literally and figuratively.
Yeah, great. Yeah, and I completely agree. Okay, one last question, and then we'll, I think, let everyone post any questions after this one. Please post them on Doc Matter. So the last question is: when you see a hiatal hernia, does that affect the way you interpret your distensibility measurements at all? Probably both of you can answer, yeah, from your own perspective.
Yeah, I mean, I think that you look at it similar as I think about it looking at manometry when there's a hiatal hernia. I think you just kind of use that as part of your clinical impression and recognize that the mechanical effects of the hiatal hernia can impact distensibility at the EGJ. And so you can have reduced EGJ distensibility with a hiatal hernia, and it's not going to be achalasia. So similar with how you would use manometry in that scenario, and just recognize them.
Yeah, it depends on the size of the hernia. I mean, obviously a smaller one probably won't do very much, but I'm careful about how the catheter is oriented beyond the G junction into the hiatus hernia, because sometimes if there's a bit of distortion, the catheter can be jammed against the wall on one side, and that obviously can affect the measurements that you get. But yeah, you have to take it into context.
Okay, great. Yeah, so I think we're out of time. So thank you both for wonderful talks. I know I didn't get to a few questions, so please, if you could post them on Doc Matter, you can see the website there. We will get you answers to them. So thank you everyone for coming. I hope you enjoyed it. Thanks.
All right. Thanks everybody.
Thank you. Bye-bye.